So Medicare is very involved. It's very complex. The transition from group health coverage or group health plan or an individual health plan to Medicare can get a little tricky. And if people make mistakes as they're going through the transition, there can be lifetime penalties imposed by the federal government if a mistake is made, or there could be a gap in coverage sometimes. So we take this transition service very seriously at MDA. We've helped a lot of members, their friends, family members, and so on with the transition. So my goal is to help you avoid mistakes and try to make that transition as smooth as possible. So the Center for Medicare Services is the entity that oversees the Medicare program. They establish the rules, and there are 160,000 pages of rules with Medicare, so there are quite a few. They prohibit me or anyone else that's putting on an educational seminar relating to Medicare from sharing any specific insurance company product or price information during an educational seminar. So I'm going to talk about Medicare enrollment, timeframes, rules, the various parts of Medicare and how those work. I'm going to spend a fair amount of time talking to you about items that can cost you money out of pocket. Then we'll get into the actual coverage options and things that you'll need to consider. And I'll take you all the way up to the point of not being able to share individual insurance company product information with you. But I will give you a ballpark in terms of how much do some of these plans cost generally, but not from a specific company. So we'll first cover the overview and the enrollment process. You've all heard that there is no I in team. I know you've heard that phrase, but there is an I in Medicare. And to me, it definitely stands for individual, your individual health needs, your preferences, how you consume your health coverage or health care as a consumer. The Medicare plans themselves are for individuals. So they don't include your family members. If two partners and a couple are both Medicare eligible, they may end up on the exact same plans by coincidence. They may end up on completely different plans because one may have different health needs or prescription needs than the other. So there is no one-size-fits-all solution to Medicare in terms of your coverage. And certain actions are time sensitive. If you don't act on time, it can cost you. I had dealt with one of our members about 6 months ago who was 72 years old. He was actively working. He did not sign up for Part B of Medicare when he was 65 years old because he misinterpreted the rule. And he was very upfront about that. He thought that because he was covered by a group health plan and continuing to work, that he did not have to sign up for Part B. The full rule relating to being covered by a group health plan is you don't have to sign up for Part B if the employer offering that group health plan has more than 20 employees. The majority of our members have fewer than 20 employees, including him. Well, because he didn't sign up at age 65, he was hit with a 10% late enrollment penalty for every 12-month, full 12-month period that he was eligible for Medicare but didn't sign up. So in his case, he was going to be hit with a 60% penalty, which is a 10% penalty times 6 full years. I didn't do this in front of him. Of course, I calculated this when I was driving home, but if he lives to his full lifetime expectation in the state of Michigan for a male, he will pay $30,000 in penalties between age 72 and his life expectancy because he made one mistake. So, and there's no recourse for that with Social Security or Medicare. So those are the kind of things that are very unfortunate. He didn't do it on purpose, it was a mistake, but that's the type of thing that we definitely hope to steer you away from. So Medicare is for folks that are 65 and older, either actively working or retired. It's also for folks that are under 65 if they have certain disabilities and have been declared by Social Security to be disabled. And then they can be of any age if they have end-stage renal disease. The enrollment is actually done through the Social Security Administration, the enrollment for Medicare. So for those of you that may be aging into Medicare in 2020 or 2021, you will enter what's called your initial enrollment period, your IEP. It's a 7-month-long period. It begins on the first day of the month, 3 months preceding your birthday month. Then it also includes your birthday month and 3 months after. So for those, let's say someone has an August 1st or an August birthday, 2020, they will be eligible to begin their enrollment process in Medicare tomorrow on May 1st, 3 months in advance of their birthday month. If someone enrolls in the 3 months prior to their birthday month, then their Medicare will start on the first day of their birthday month. So in this example, the individual who is eligible to enroll after May 1st or on May 1st will have an August 1st effective date for Medicare. So it's not, the effective date is not on your birthday, it's on the first day of your birthday month. So which parts of Medicare should someone enroll in? Well, the first thing to point out is if any of you are already drawing Social Security retirement benefits or Social Security disability benefits, Social Security will actually automatically enroll you in Part A, the hospital coverage, and Part B, the medical coverage. And then they'll automatically mail your red, white, and blue Medicare card to you in a few months in advance of your birthday month. So for those folks, they'll get an automatic enrollment. For the rest of us, we have to actively enroll. So depending on what your situation is in terms of the health insurance coverage you have now, if you're currently covered by COBRA, an individual health plan like a Blue Cross Blue Shield My Blue individual plan, a group retiree health plan, but you're no longer actively working, or a group health plan offered by an employer that has fewer than 20 employees, or an Affordable Care Act exchange plan, one of the marketplace plans, you must enroll in Medicare Part A and B. The reason for that is in all of these instances, Medicare is primary payer on a claim, and any of these other coverages would be secondary payer on a claim. So in order for Medicare to be primary, you have to be enrolled in Part A and B. The exception to that is if someone is still actively working and they're covered by a group health plan that is offered or provided by an employer that has more than 20 employees, then the group health plan is primary payer on a claim and Medicare is secondary. So in those instances, an individual would still want to enroll in Part A so that they have the hospital coverage as a backup, but they can delay their enrollment in Part B. Delaying your enrollment in Part B means you don't have to pay the Part B premium to the federal government each month for the length of time that you will still be covered by that group health plan. So if someone is covered by a group health plan where there are more than 20 employees and they're aging in at age 65, but they hope, you know, to work till they're age 70, then for 5 years or 60 months, they're not going to have to pay the federal government for the Part B premium. So in terms of timing, we at MDA strongly encourage our members to enroll 90 days prior to the first day of their birthday month. There are several reasons for that, especially now during the COVID-19 crisis. In a normal situation, once someone enrolls, it will still take anywhere from 3 to 4 weeks after they enroll before the red, white, and blue Medicare card arrives in their mailbox. So this person that might enroll on May 1st that we're talking about, if everything goes smoothly and they successfully enroll, now they're another month down the road, closer to their August 1st effective date. So now it's around June 1st. That gives them time to meet with me or someone else to pick out their plans, complete their applications, and so on. An individual cannot fully complete an application for a Medicare supplement plan, a Part D prescription plan, or a Medicare Advantage plan without physically having their Medicare card in front of them, because every application requires that you fill out the information off your Medicare card onto that application. I'm going to come back to the enrollment process in a minute. Dr. Colling and I have had some discussions about this situation, and it can get complicated. But once someone is enrolled in Medicare Part A and or B, and they have started their effective date, or they've reached their effective date, they can no longer contribute to a health savings account. So, and that's set by law. So in the year that an individual is going to transition into Medicare, if they're on what's called a high deductible health plan that's eligible for an HSA, they would end up making a pro rata contribution depending on what month they transitioned into Medicare. So again, using the example we've been talking about with an August 1st effective date, that individual would make a 7/12 contribution to their HSA to get them through the month of July. They would still have until April 15th of 2021 to make the contribution that's set in federal code, but they can only contribute through the end of July. If someone's in that situation, the family contribution in 2020, the maximum contribution is $7,100. I've broken it out by a monthly contribution amount there, so you could do the math for yourselves. If they have individual coverage, the maximum is $3,550. But for anyone who's over 55 years old, you can also contribute another $1,000 on an annual basis. So in this case, that we've been talking about, let's say the person who is going to have the August 1st effective date has family coverage. They would multiply the $591.67 times 7 months, and then the $83.33 times 7 months. That's what the contribution could be. Now, if there's a younger spouse involved who is not going to turn 65 in that transition year, as long as that person's name is on the HSA account, they could then contribute. So if this individual started out with a family contribution that had to stop come August 1st, and their spouse went at that point on to individual coverage, they could complete the year making the individual contribution per month. So just a reminder, because I do get questions about this every once in a while. When you do enroll in Medicare, the enrollment is just for Part A and Part B. Every once in a while, a member will call and say, well, I couldn't find where I was supposed to enroll in Part D. You can't enroll in Part D on that Medicare site. Part D plans are sold by private insurance companies that are approved by Medicare, so that comes later. So again, when you're enrolling, it's just for Part A and B. Now, I'm going to come back to why we encourage our members to enroll 90 days in advance. There are 3 enrollment options that a person can use. They normally could go down to the local Social Security office and apply there. They could call Social Security, or the easiest way to do it is to enroll online. The local Social Security offices are all shut down now because of COVID-19. Folks that have had to call Social Security, some of them have sat on hold for 2 to 3 hours. So the easiest way to enroll is to do it online. You'd go to www.ssa.gov. Now the application normally is fairly straightforward, but trying to get to the application from Social Security's homepage is a little tricky. So I'm going to walk you through some click-through steps once you get to that homepage. So this is what the homepage looks like at Social Security. In the bottom right corner, where the couple is looking at one another, where you see the words Medicare enrollment, you want to click on that picture. It'll take you to this landing page, and that bright blue rectangle in the middle of the page that says apply for Medicare only, you want to click on that. Then you'll be at an attestation page where you have to say that you have read the terms and agree to those. you want to click on that box and then click on next. And then you'll finally be on this page, and you'll want to click on that rectangle that says start a new application. Once you do that, it will actually, the next page will be the application. So again, you have to jump through some hoops to get to the application. Now, some of you may be, I should have told you this at the beginning, some of you may be scrambling with pens and papers, which is fine to take notes and so on, or trying to take pictures of the slides. After the seminar, it probably won't be today, it might be Friday or Monday, but I will, we will email the PowerPoint to each of you, providing we have your email addresses. And then you'll have all the information and reminders of these click-through steps. Now, it normally, historically, took maybe 15 minutes to complete the Medicare application. On January 1st, 2019, Medicare added a little twist to the application. They thought they were helping all of us. Their intent was admirable. They were trying to create security measures so that they would be able to verify that the person that was applying was actually you. Well, they ended up confusing a lot of people and causing some delays for some folks. What they have done, and I can't tell you exactly what questions they will end up asking each of you, because the questions will all be different, but I'll give you a couple of examples. They're going to ask you questions such as, in 1988, you had a car loan with one of these 4 finance companies, and you have to remember or guess which one you had the loan with. They may ask, on these 4 addresses listed below, which one is associated with your name? Well, I dealt with one of our members about a month ago where they had listed an older residential address as well as the dental office address. The member didn't know how to answer that question because in the government records, both of those addresses would have been associated with that individual. So the point here you've got to be very careful and think through these questions, because if you get one of the questions wrong, you will be locked out of the application. The normal recourse when that happens is the member just goes down to the local Social Security office and they meet with a representative and they complete the application. You can't do that right now because the offices are all closed. So if that happens, you're going to have to call the Social Security number. They're going to give you a couple of choices. You can wait on hold, and as I said, that could be for a couple of hours, or you can leave your name and phone number. They will call you back. But I have had a couple of members locked out of the application over the last month. They did leave their contact information, but it took a week before Social Security called them back, but they did call them back. So again, that's one of the other reasons we encourage you to enroll as soon as you can, as soon as you get to that 90-day out situation. Once you're enrolled and once you start Medicare, every fall between October 15th and December 7th is Medicare's annual election period. During that time, if you want to, you can change plans. If someone does make a change, then the new plan would take effect January 1st. If you're on a plan you like and the carrier is not going to make substantial changes to that plan in the upcoming calendar year, you don't have to do anything. The plan will just roll over into the new year. So I'm going to get into the parts of Medicare and the coverage gaps, or the areas that you would financially be responsible for. So there are 4 official parts of Medicare. Part A is the hospital coverage, and that's provided by the federal government, the federal Medicare program. Part B is the medical coverage or the outpatient coverage. That's provided by the federal government. Those 2 parts, A and B, are referred to as original Medicare. Part C of Medicare are actually Medicare Advantage plans that are sold by private insurance companies that are approved by Medicare. And then Part D are the prescription drug plans. Those are sold by private insurance companies approved by Medicare. You can access the Part D prescription coverage in one of 2 ways. You can get a standalone Part D drug plan that you would pair up with a Medicare supplement plan, or most of the Part C Medicare Advantage plans have Part D drug coverage embedded in the plan. So and some of you have heard me say this before, I'm a very visual person, a visual learner, and so on, and my brain operates in funny ways. But when I hear the words original Medicare, this is exactly what pops into my brain. I view original Medicare as a slice of Swiss cheese from the deli with all the holes in it. And to me, the holes are the deductibles, the co-pays, and the co-insurance that are part of original Medicare. And as you can probably tell by the camera, I like food, probably like it too much. So I'm going to continue the food theme for a minute. If someone chooses to go with a Medicare supplement plan, depending on the plan that they go with, that would be like putting a slice of cheddar cheese or American cheese behind the Swiss. You can either block a few holes or you can block every hole but one. So it all depends on which of the supplement or Medigap plans someone decides to go with. Now, original Medicare A and B will not pay for any of these things listed here. So because they don't pay for, original Medicare doesn't pay for these things, a supplement or a Medigap plan will not step in and pay for these things, except for that healthcare while traveling outside the US. There's an exception there. Now, the key word here on the eye care and on the foot care is routine. So they're not going to pay for me to go to my optometrist to find out if I need to have my lens prescription upgraded. But if I had macular degeneration or glaucoma, some other medical condition related to the eye, Medicare will pay for that. If someone has neuropathy because of diabetes, or last fall, I had plantar fasciitis, had to get some cortisone shots in my heel, they paid for that because it wasn't deemed routine. So with Medicare, there are often exceptions to the rule. I'm not going to say always, but there are often exceptions. So the Medicare Part A coverage operates like this. It covers hospital stays, home health care services, skilled nursing care after a hospital stay, some hospice care. The first thing you have to keep in mind if you're going to use Part A is Medicare requires that you be admitted as an inpatient for 2 midnights. They have their own lingo at Medicare. So you have to be admitted for 2 midnights. If you are admitted for 2 midnights, then there's a $1,408 deductible in 2020. These numbers that I'm going to go over with you can change every year. They're tied to the congressional budget bill. So they may get tweaked by a few dollars every year. But in the current year, there's a $1,408 deductible if you're admitted. But it's not an annual deductible like we're used to. So this is where Part A is a little different. So a benefit period begins when you're admitted as an inpatient for the 2 midnights, and it ends when you've been released and you've been out of the facility or have not received inpatient care for 60 days in a row. So 8 weeks ago, I had knee replacement surgery. When they released me and sent me home, if I had to go back in the hospital, say 30 days later, either for the knee or it could have been a new condition, I would not have had to pay that $1,408 deductible again because I would be in the same benefit period. But if I had to go back in the hospital and it was 65 days after they released me, now I'd be in a new benefit period and I'd have to pay that deductible again. So after the deductible is satisfied, and I'm talking in terms of me paying it or you paying it, but just keep in mind that there are a lot of supplemental plans or Medigap plans that will pay it. So once that's satisfied, Medicare will pay and cover you for the first 60 days of your hospital stay at no additional cost. If you're still in the hospital 61 to 90 days, they'll still cover you, but now there's a daily copay that you're responsible for of $352 a day. If someone is still in the hospital 91 to 150 days, that copay doubles to $704. The Part B medical or doctor coverage is very similar to what most of us are used to with our group health coverage. It's an 80-20 plan. It will pick up 80%. You're responsible for 20%. That 20% though with Medicare is unlimited. There's no cap, no out-of-pocket cap to it. It has a small Part B annual deductible of only $198 on the B side. B will pay for doctor visits and services in the hospital or their office, outpatient procedures, lab tests, preventative services, durable medical equipment, and so on. So it's a pretty thorough type of coverage. As I talked about our member friend who was 72, simply not enrolling in Part B may mean high premiums. There's a 10% penalty for every full 12-month period that someone did not sign up when they were eligible. And that penalty gets added to your Part B charges that you have to pay the government. There's no federal penalty assessed if you enroll after age 65 because you have been covered by group health coverage where there were more than 20 employees. So at that point, the government gives you what's called a special enrollment period. And that special enrollment period mimics the initial enrollment period that you were granted when you aged into Medicare at age 64, 65. So these are all the holes in the Swiss cheese at a quick glance. Across the top are the Part A hospital charges that we had talked about. Across the bottom row are the Part B charges, the deductible, the co-insurance. They don't cover, original Medicare does not cover prescription drugs, and they of course don't cover non-covered services. So I'm going to focus on this middle row for a minute and explain the relationship between your Part A hospital coverage and having coverage in a skilled nursing facility. So again, the first part of the rule for Part A to kick in and cover you is you have to be admitted for 2 midnights as an inpatient. There's a second part of the rule that relates to skilled nursing, and that is you have to stay in the hospital 3 days, not counting the day of discharge, for your doctor to be able to write a skilled nursing care order so that you would have Medicare coverage in a skilled nursing facility, say for rehab after orthopedic surgery or something. If you meet all those requirements, then Medicare will cover you at no cost for the first 20 days of your stay. They'll also cover you days 21 up to 100 days in that skilled nursing facility, but beginning on day 21, there is a $176 per day copay that you're responsible for. After 100 days in the skilled nursing facility, Medicare stops paying. You would be on your own if you were to still stay in that facility. And then off to the right, I don't know how they came up with this, but they won't cover the first 3 pints of blood if you need a transfusion. Just kind of strange. So there are other things that can cost you money out of pocket that I want you to be aware of. So one of those things is the type of provider that you're dealing with, that you're getting your treatment or procedures from. The vast majority of hospitals, clinics, doctors, and so on are in this top category. They participate. That means they accept Medicare patients, they'll direct bill Medicare for you, and they accept Medicare assignment. And again, I'd say, gosh, 98% of the providers are in that category. In the second category, this is kind of a slowly emerging group. It's kind of, to me, it's kind of a misnomer that they call them non-participating, but they probably didn't have any other names for them. A lot of them will still accept Medicare patients. A lot of them will still direct bill Medicare for you. But what they don't do is they don't accept Medicare assignment. They say it's too little or too low. So by law, they're allowed to charge you 15% more than the Medicare eligible amount. And those are called limiting or excess charges. The last group, number 3 to be aware of, these are private contracting providers, opt-out providers, or concierge providers. There is no contractual or financial relationship at all between those providers and Medicare. There will be no reimbursement that will take place. You can't go to them and pay them and then submit a claim to Medicare for you to be reimbursed. So if you deal with this level of provider, you're on your own to pay 100%. The other thing to be aware of, and this normally occurs when someone goes into the hospital through the emergency department. And some of you have probably experienced this before. You know, sometimes after 5, 6, 7 hours of being in the little examining room, the doc comes in and says, you know, I've had 3 of my colleagues look at you. We've run 6 different tests. We're not sure what's going on. We're going to send you upstairs. Well, most people would assume they're being admitted as an inpatient. But in a lot of cases, they're being sent upstairs and they're being placed under observation. When you are, again, when you're not being admitted for 2 midnights, you have no Part A coverage. You would only have coverage under Part B if you're under observation, but you'd have coverage. Where it gets dicey is if whatever's wrong with you requires that you do go into a skilled nursing facility after that hospital stay, because you would have no Part A coverage for that skilled nursing facility. This became such a national problem a few years ago that Congress passed a law back in 2016 that required that hospitals now use a standardized form called MOON. It stands for Medicare Outpatient Observation Notification. If someone has been under observation for more than 24 hours, the hospital must notify them in writing using this form and explain the reasons that they're under observation. And then that patient has to countersign the form saying they understand. But Congress left a loophole in the law. The hospital has to notify you again if you've been in observation for more than 24 hours. But the hospital has 36 hours to tell you that you've been under observation. So I'm not sure why they didn't match those 2 timeframes up, but they didn't. Under Medicare's rules, there are very black and white rules that say under these circumstances, a patient should be admitted. Under these circumstances, they should be placed under observation. But just as it, like everything else in life, there are gray areas sometimes. When those gray areas occur, it's up to the hospital to make the call in terms of which way they're going to place a patient. The hospitals tend to err on the side of observation because Medicare does hold the threat over the hospital's head that if they admit someone, Medicare can come in and audit the patient records. If they determine that that patient should have been placed under observation, they'll financially penalize the hospital. So I'm not going to, these are very lengthy, so I'm not going to get into those today, but when we do send you the PowerPoint, this is the definition of inpatient admission. These are the guidelines for physicians to follow. And then this is the definition of observation and why someone should be placed under observation. So I just wanted to point out how the observation works versus inpatient. And keep in mind, again, this normally happens. If it's going to happen, it happens because someone went into the hospital through the emergency department. So we're going to talk about Medicare's basic costs. Throughout your adult lives or your careers, you or someone on your behalf has paid one monthly premium to an insurance company for your health coverage. Well, Medicare is different. You're going to pay out of both pockets, if you will. You're, on the one hand, you're going to pay the federal government out of your left pocket. That premium is going to be based on your income from 2 years previous. You'll pay a premium for Part B. And if Medicare determines that you're a high income earner, they will also assess a surcharge or a tax if you are enrolled in a Part D prescription plan through an insurance company. Then out of your right pocket, whatever plan you decide to go with, plan or plans, which could be a Medicare Advantage plan, a Medicare Supplement plan, a Part D prescription plan, or a group retiree health plan, to fill in the holes of original Medicare, you would pay the insurance companies a monthly premium for that coverage. So you're paying out of both pockets with Medicare. So in terms of the costs to the Medicare program itself, your Part A hospital coverage will be premium free to you because you've paid into FICA for at least 10 years. The Part B premium will be paid to the federal government. It's based on your modified adjusted gross income from 2 years previous. So if someone is aging into Medicare in 2020, after you enroll and right around the time that you're going to receive your Medicare card in the mailbox, you'll get a letter from the government, and they'll basically, I'm paraphrasing, but they're basically going to say, we've gone in and looked at your 2018 1040 based on your modified adjusted gross income, which doesn't appear anywhere on the 1040, by the way. So what they look at is adjusted gross income and interest income. And from those two things, they calculate your modified adjusted gross income. They'll then tell you how much you're going to pay monthly or what your monthly charge will be for Part B. Now, they do this every year. It's based on a calendar year cycle, but most people don't start Medicare initially on the calendar year. So for the first part of the year when you transition in, you'll pay that amount. And then around November, you'll get a letter from the government and they'll say, in this case, they'll say, we've looked at your 2019 tax return. This is what you're going to pay us beginning in January of 2021. So they'll adjust it every year. Now, everyone who is on Medicare pays a base amount for Part B. So there are 68 million people on Medicare. They all pay at least $144.60 a month. 95% of those folks just pay the $144.60 per month for Part B. But anyone filing a joint tax return back in 2018 who had an income greater than $174,000 is considered a high income earner, and they're going to pay an additional amount above the $144.60 on a sliding scale. And then again, those folks that also are deemed to be high income earners will pay a Part D tax or a surcharge in addition to the Part B. So this is the chart for 2020. Again, the folks that just pay the $144.60 are those filing a joint tax return who had an income of less than $174,000. and they don't get hit with a tax or a surcharge because they're enrolled in a Part D drug plan. So their total charge is $144.60 a month. But then there's this sliding scale with these other income ranges. So you can see that that Part B number continues to increase depending on where someone's income was. And then from the 174 range up to 218, that's where the tax or the surcharge for Part D comes into play. So then you'd be looking at total charges. The first notification you're going to receive, though, will just deal with Part B, because you always receive that letter prior to your Medicare beginning or starting. And so at that point, they don't even have an idea that you've signed up for a Part D plan. But at some point after your effective date, they'll have an aha moment once you fill a prescription or once you complete your application for a Part D plan. And they'll send you another letter and say, this is what you're going to pay in a tax or a surcharge for Part D. Now, when you pay the Part B premium, whatever it might be, you're getting something in return for that. You're getting your Part B.
And I just called the back. They wanted to go through.
The Part D, you get nothing in return for that. It's simply a tax or a surcharge.
No, I didn't see that.
This is a video from the MDA
Okay.
for 2.5 hours worth of credit
Gosh,
on things I already know.
Oh, all right.
So you're going to be there till she's released?
Oh, yeah.
So this is the chart for the individual tax return, someone filing individually. The numbers are a little different across the top, but the monthly numbers are the same. Now, for those folks who are drawing Social Security benefits, the government will just take your monthly charge out of your Social Security check and send you the difference. For those of us that are not drawing any Social Security yet, the government will take our monthly amount, multiply it by 3, and mail us a quarterly invoice. And then we'll just write a check. And then when the day eventually comes that we start drawing Social Security, then they'll take the monthly amount out of our checks. Now, for a lot of you, you're going to reach a point because of cutting back on hours, selling the practice, retiring, could be because of COVID-19, where the amount of income that the government is looking at from 2 years previous is not anywhere close to what reality is in the present day. In other words, it's much higher 2 years ago than it might be in the present day. When you reach that point, you can file an appeal form. It's SSA-44. And it's easy, just you can Google it, SSA-44 appeal form. It'll come up. You'll actually see the form that you need to fill out and the filing instructions. It's basically a life-changing event appeal form. And I'm going to paraphrase, but what you're saying by filing this form is, hey, I know the income you're looking at from 2 years ago is high, but that's not reality today. Would you please go back in and reconsider how much you're going to charge me for Part B and D? And in a lot of cases, they will adjust it down. The worst they can say is no, but the only thing you have invested at that point is a little bit of time to fill out the form. But if you don't ask, obviously they're not going to reduce it. So if you're in that situation, or when the time comes that you are in that situation, it's worth filing. Okay, so once you are enrolled in Medicare A and B, there are two ways that you can actually get your coverage to block or address these holes in original Medicare. On the one hand, you can use original Medicare A and B and fill in those coverage gaps with a Medicare supplement plan, or the other name for it is Medigap plan. It really just depends who you're talking about, which insurance company you're looking at, but Medicare supplement and Medigap are the exact same thing. Those plans pay only after Medicare approves and pays. So the first thing that has to happen with a supplement is Medicare has to say, yes, this procedure or treatment is an eligible expense. Then they will pay. If they don't happen to pay everything because of a deductible, a copay, or a coinsurance, depending on your Medicare supplement plan, that's what triggers the supplement to then step in and pay. If, let's say I was trying to have cosmetic surgery, Medicare will say, time out, no, we don't cover cosmetic surgery. At that point, there's no supplement plan or Medigap plan in the United States that will step in and pay, because they have to follow Medicare's lead. On that side of things, using original Medicare and then using the supplement, it doesn't matter where you are in the United States, you just deal with Medicare providers and you're always in network. You don't need a referral to see a specialist. So it's a wide open national network. On the right side, once you're enrolled in Part A and B, a Medicare Advantage plan, or Part C, replaces original Medicare. So Medicare Advantage plans are an alternative form of coverage. They're known as private Medicare, and those plans pay instead of Medicare. So the folks that go with the Medicare Advantage plan are no longer getting their benefits from the federal Medicare program. They're getting them from the private insurance company they purchased the plan from. But you still have to pay your Part B premium to the government for Medicare. There's no getting around that. So I'm going to compare and contrast these two choices. And keep in mind that an individual's choice needs to reflect their lifestyle, their health status, their desire for provider flexibility, their risk tolerance for out-of-pocket costs, and their budget tolerance, you know, what they're willing to pay per month in premium. So on the supplement side, there are 8 plan options that are controlled by the federal government. So they're standardized and controlled by the federal government. Those plans start with a letter of the alphabet, and they're plans A through N. Every plan is different. Plan A, for instance, would leave the most holes open in the Swiss cheese. Plan G would block every hole except for one, which is the Medicare Part B annual deductible of $198. These Medicare supplement plans charge a premium, of course, in addition to the Part B government premium. Typically, an insurance company selling a Medicare supplement plan is going to look at 3 main things when you're aging into Medicare if you apply for a supplement plan. They're going to look first at community rating. Some companies look at, does this individual live in Southeast Michigan or do they live in outstate Michigan? While other insurance companies will look at the first 3 numbers of your home zip code. So those companies break the state up even into smaller pieces. Then they look at gender. Females are less expensive on Medicare supplements than males. And then a thing that's unique to Medicare supplement plans is they'll look at attained age. So if I were dealing with a member who lived in Southeast Michigan, a female, turning 65, transitioning into Medicare, I would look at those three things to determine her rate. The thing that's unique about the supplements is the attained age portion of the premium calculation ticks up each year that you get older. So that part increases each year that you get older. Over on the Medicare Advantage side, again, those plans replace original Medicare. The plans, the benefits, and the provider network vary by insurance company. The plans come in the form of an HMO provider network or a PPO provider network. You literally pay out of pocket, you personally pay out of pocket for your deductibles, copays, and coinsurance that are part of that particular plan until you hit the maximum out of pocket number for that particular plan. Of the plans sold in Michigan, the out-of-pocket maximum, annual out-of-pocket maximum ranges anywhere from $3,500 to about $6,800 on a Medicare Advantage plan. Some of the companies actually offer zero monthly premium plans. Most plans charge a monthly premium, however, and the premiums are simply based on the region in which you live, and the regions are really made up of the county that you live in. So on those premiums, they don't take gender or age into account. It's just what county do you live in. So we talked early on about the 7-month-long initial enrollment period when you're first transitioning into Medicare. If an individual decides they want to apply for a Medicare supplement plan when they're aging into Medicare, when they're in that initial enrollment period, they are guaranteed issue when applying for a supplement, but only during that time. So a person with 4th stage cancer, if they were in their initial enrollment period, an insurance company would have to grant them the policy they applied for at the standard rate. If an individual keeps that Medicare supplement plan and continues to pay their premium, then every calendar year, they're guaranteed renewable. That plan cannot be taken away from them because their claims might get high. They can't be singled out and have their premiums individually spiked because they had high claims or have a bad health history at that point, as long as they have kept the same plan. You have freedom of choice in your medical care. Again, the network is any Medicare provider anywhere in the United States. The thing about Medicare supplements is they don't have prescription coverage. So the folks that go with a Medicare supplement plan also enroll in a standalone Part D drug plan. And then they pay that premium to the insurance company that sponsors that plan. On average, this is certainly not always true by any stretch, but on average, the monthly premium for a Medicare supplement plan is a little higher than for a Medicare Advantage plan. But depending on which of those 8 plans someone goes with, you have a much lower out-of-pocket risk with a Medicare supplement. Over on the Medicare Advantage side, those plans can be changed or dropped from one year to the next. In other words, Sometimes the insurance companies tweak their plans from one year to the next. You can't be dropped from an ongoing plan though. So if they're going to continue to offer that plan, they can't boot you from the plan because you had high claims or anything like that. In a traditional Medicare Advantage plan, if you were to look at the summary plan benefit, to look at the detail of the coverage, you would see that there's an in-network column of benefits and an out-of-network column of benefits and co-pays, deductibles, and co-insurance. If you go out of network on a traditional Medicare Advantage plan, then your costs are going to be 40% higher than in network. So you don't want to go out of network with one of those plans. Many of the Medicare Advantage plans incorporate or integrate a Part D drug plan into the plan. And then many of those plans include an additional basic benefit for dental, vision, hearing, and a lot of them have a health club membership called Silver Sneakers, which is a very popular feature of a Medicare Advantage plan. On average, and again, this is not always true because some of the Medicare Advantage plans can get quite expensive, but on average, the premium for a Medicare Advantage plan is usually lower than for a supplement, but your out-of-pocket risk is much greater on a Medicare Advantage plan. So schematically, this is kind of what your choices look like. Most of you, unless you're receiving a group health plan of that's provided by an employer who has more than 20 employees, most of you are going to be enrolled in Part A and B. And now you know there are gaps in the coverage that you want to take care of. So down the left side, one option is to go with the Medicare Supplement plan, and then you would pair that with a Part D prescription plan. On that side of things, again, it's just a wide open national network of Medicare providers. On the right side, those are the Medicare Advantage plans. At MDA, I know this probably sounds harsh sometimes, but I just want to be very direct with you in case you have an interest and you know that you want to go somewhere else. At MDA, we have access to HMO network Medicare Advantage plans. I have never placed one of our members in an HMO plan. I don't have any intention of starting anytime soon because you wouldn't be very happy with me a year down the road. Our members who are interested in Medicare Advantage plans, we always place them in a PPO network plan because the PPO networks are a lot more expansive. You have a little more freedom of choice in terms of doctors that you want to see and treatments and procedures and so on. So for those of you that might be interested in Medicare Advantage, just know that it would be a PPO plan through us. So this isn't going to make a lot of sense when I say this, and I'll try to explain it. But the government says to the insurance companies that offer Medicare Advantage plans, the plans must cover everything that original Medicare covers, Part A and B. However, the plans can vary in how they cover those things and how much an insurance company is going to pay. So what I mean by that is they're two completely different animals in terms of how they approach the coverage. With a Medicare supplement plan, you're using original Medicare. So going back to the Part A coverage, if you're admitted as an inpatient for 2 midnights, you would have to satisfy that $1,408 benefit period deductible that we talked about. But if you have a supplement plan, many of the Medicare supplement plans will pay for that. On the other side, Medicare Advantage, if you are hospitalized on a Medicare Advantage plan, you're not dealing with a $1,408 deductible anymore. Instead, and it varies by each plan, beginning on day one of your hospitalization, you're responsible for a copay amount that you're going to pay out of pocket. The plan's not going to pay it. And again, depending on the plan, you may pay that copay day 1 through day 5, or you may pay it day 1 through day 6. And the amount can vary. It can be anywhere from $200 a day to $375 a day. So they're still providing hospital coverage on either plan, but the way you approach it or the way the carrier approaches it is very different. There are not any health questions on a Medicare Advantage application like there are on a Medicare supplement. We haven't gotten into that yet. I'll cover that in a second. And on a Part D drug plan, there are no health questions on the application either. Medicare or CMS reviews the Medicare Advantage plans and the Part D prescription plans on an annual basis. They look at 44 performance measurements, and then they rate these plans using a 5-star rating system. 5 is excellent, 1 is poor. We don't have any 5-star plans in Michigan, and it's not that we don't have very good plans. We have excellent plans, but the government makes 5 nearly impossible to hit. The government pays these insurance companies for every star rating above a 4, in half-point increments. The government literally pays the insurance companies millions and millions and millions of dollars a year for every star rating above a 4. And that's one of the reasons that some of these companies can offer 0 premium plans. Usually, most of the 0 premium plans are HMO network plans. On the Medicare supplement plans, and I know there's a slide in here, well, it's next. I'm going to jump to that and then I'll come back. So again, we had talked about the guaranteed issue situation of, I used the example of someone with fourth stage cancer being guaranteed issue during this initial enrollment period. And as long as someone keeps that Medicare supplement plan and pays their premium, they're guaranteed renewable. Once someone leaves that initial enrollment period, that 7-month period, and they decide they want to switch Medicare supplement plans, let's say it's 3 years down the road in the fall during the Medicare annual election period, and someone started out with a Blue Cross plan and now they want to go with a United Healthcare plan. On every application with a Medicare supplement, there are 2 to 3 pages of health questions on an application. Once you get outside of that initial enrollment period, you have to answer the questions and go through underwriting. If an insurance company doesn't like your answers, they can decline you, not issue the policy to you, or they can double the premium on you. So that's a risk, that someone runs if they think they're gonna switch plans all the time with a Medicare supplement. If someone starts out as they turn 65 with a Medicare Advantage plan, and then 2 years down the road in the fall, they say, I wish I'd gone with a Medicare supplement plan. and they apply, they're going to answer all of the health questions. So they'll go through underwriting. On the Part D prescription plans, you can change those every fall during the Medicare annual election period because there are no health questions on those applications either. The government allows that for several reasons. And it's not unusual to change Part D plans in the fall. In the course of a year, an individual may have new medications added, and maybe the Part D plan they're on doesn't cover those medications as favorably as another plan. They may have medications removed that they don't need anymore, and maybe they were on a more comprehensive Part D plan to cover those medications, and without those medications being needed anymore, maybe they don't need as expensive a plan in the new year. But the other thing that happens is the insurance companies that provide these Part D plans tend to tweak their plans from one year to the next. So obviously we deal with a lot of members who are beyond age 65. And in the fall, we do a lot of prescription medication reviews to make sure that the plan that someone has been on is still going to be a good plan in the new calendar year, or they need to switch. So that's part of the service that we provide as well. Okay, so on the supplements, as I said, there are 8 of those. If we're talking about a particular lettered plan, so let's say we're talking about a plan G. If I had 20 insurance company representatives lined up down the hall outside of my office, and we were talking about plan G, you would all rest assured that the benefits and the coverage under a plan G is identical across every one of those insurance companies, because those plans are controlled by the federal government. But what you'd see is that the premium that all of those companies charged might be off by a few dollars, might be off by $10 a month, whatever. Because all of those companies have different ways of calculating their premiums. They all do take into account community rating, gender, and attained age. But they all have their current insurance pools of folks that are on the plans too, and that comes into play. So this is the chart of Medicare supplement plans. Again, there are 8 plans as of January 1st, 2020. And those are the ones that are in the white. Plan C and Plan F were dropped by Congress. They passed a law in 2015 that finally took effect January 1st of this year. Plan C and Plan F were eliminated and are not available to new persons turning 65 after January 1st. The folks that were already enrolled in a Plan C and a Plan F, and there were millions, they were grandfathered in and they were able to keep those plans. Plan F had been the most comprehensive Medicare supplement plan. It covered all of the holes in the Swiss cheese or in original Medicare. Plan G is now the most comprehensive plan. As you compare it to F, look coming down through the column, it covers everything that F did except for the Part B annual deductible, which is $198. So the folks that have a Plan G, their out-of-pocket risk for the A and B items of Medicare is $198 a year. As you look across the row labeled Part B deductible, you'll see that none of the plans cover that deductible anymore. And that's the reason that Congress eliminated Plan C and F. You've heard our elected officials say, we want folks to have skin in the game with their health care. Well, that was Congress's way of forcing people to have skin in the game, making them pay that deductible. So as you come down under a lettered plan, come down the column, so look at Plan A if you would. Wherever you see a white space, that means that that particular benefit is not covered by that plan. So you would be responsible for that particular item. Wherever you see a 100 under a lettered plan, that means that that plan will cover that particular benefit 100%. So I'm going to run through these benefits quickly, and we'll talk about these. So this Part B coinsurance, that's the 20% that you're responsible for under Part B that has no cap or limit to it. All of these plans with the 100 will pay for that. If you did need a transfusion, the first 3 pints of blood would be paid for by these plans with the 100. There's both a copay and a coinsurance with hospice care. It depends on the treatment or benefit that you're getting. These plans with the 100 will pay for that. The skilled nursing facility coinsurance, that's the $176 per day copay that you would pay days 21 to 100. The plans with the 100 will pay for that. The Part A deductible, which is the $1,408 deductible per benefit period, which I've never known anyone to have a health year this bad, but someone conceivably could pay that 6 times in a calendar year. Even if it were 6 times, these plans with the 100 will pay for it. None of the plans will pay the Part B deductible anymore. And the Part B excess charges, when we went over the 3 levels of providers, the number 2 category, those folks don't accept Medicare assignment. So you'll remember they can charge you 15% more than the Medicare eligible amount. Plan G will pay for that if you incur those charges. Now with Medicare, as long as you're in the 50 states or a US territory, you'll have Medicare coverage. But if you go to Canada, Mexico, or overseas, there's no Medicare coverage. So the federal government built in to these 4 plans, D, G, M, and N, a foreign travel emergency benefit. It's standardized by the government, and it operates like this. Let's say you are in London and something happens over there. You will pay the hospital over there out of pocket. When you get back to the States, depending on which insurance company you went with, you would file a claim. You'd pay a $250 deductible. The plan will pay 80% of the Medicare eligible charges. You'll pay 20%. It's better than nothing, but it's not ideal. So here's why it's not ideal. That coverage has a $50,000 lifetime maximum benefit. So it's not finite. Or it is finite, excuse me. And it does not have medevac coverage. So on our MDA website, which is mdaprograms.com, there is under health insurance, there's a header you can click on that's called travel insurance. The landing page that will pop up is for a Blue Cross product called Geo Blue, G-E-O Blue. And when you're on that page, it's at that point, it's pretty much a self-serve kiosk. You can get travel health insurance for a single trip, multiple trips throughout the course of the year, however you want to do it. But they're simply going to ask for your home zip code, the ages of the people that are traveling, and how long you'll be gone. You hit search. It'll bring up 3 different quotes with different levels of coverage. It's relatively inexpensive, but the benefit of that is it has a direct bill feature with over 200 countries around the world, and it does have medevac coverage. So if it were me, if I were traveling overseas, I have a supplement, Medicare supplement plan. I would still supplement my supplement with a travel insurance plan. Again, whether it's a Geo Blue or you get one from your travel agent, I would still get the added protection, because if you have to do a medevac, you could burn through that $50,000 lifetime maximum in the blink of an eye. So just wanted to pass that on to you. All right, so I'm going to give you some ballpark premiums, because you're probably wondering, well, what do these things run? This is for Medicare Advantage plans that are sold in Michigan, and I recognize that this is a huge spread, but these are real numbers. So this would be for a Medicare Advantage plan with prescription coverage built in. Those are called MAPDs, Medicare Advantage with prescription drug. These would be PPO network plans with the basic benefit for dental, vision, hearing, and the health facility coverage, silver sneakers. Again, the premium is based on the region where you live or the county. And the premiums, believe it or not, run from $0 a month up all the way up to $299 a month. I'd say the average, if there is such a thing, and again, it depends on your county, might be anywhere from $68 to $86 a month for a fairly decent plan. But the reason I have this teeter-totter picture on here is it operates like a teeter-totter. The lower the premium, the higher your out-of-pocket maximum, and vice versa. So again, in network, your annual out-of-pocket in Michigan plans are going to run $3,400 to $6,400 to $6,800. If you happen to go out of network, then your out-of-pocket maximum would be anywhere from $6,000 to $8,100. So ballpark premiums for a Medicare Supplement Plan G sold in Michigan. At age 65, a female would run anywhere from, depending on the carrier, anywhere from $94 a month to $142 a month. For a male age 65, a G would run anywhere from about $104 to $162 a month, and anywhere in between. Again, the rates depend on the insurance company, where you reside, attained age, and so on. Household discounts can apply depending on the carrier. There's one carrier, or a lot of carriers, I should say, where if both members of the couple have a Medicare plan with that company, then they'll offer a discount. It could be anywhere from 5 to 10%. There's another carrier who has a really neat discount. They'll give you a 12% discount if you just live with someone who's 60 years old or older. That person doesn't have to have a plan with that carrier. In fact, they don't even have to be on Medicare. For that plan G, the out-of-pocket cost or the out-of-pocket risk is the Part B annual deductible of $198. So we're going to talk about Part D now. As if your heads probably aren't spinning already, Part D is probably the most confusing part of Medicare. So the government would tell you, and this is true by law, that having a Part D drug plan is optional. And it is optional. But if you go 63 days beyond the end of your initial enrollment period without enrolling in a Part D plan, the government will begin to accrue a permanent penalty against you. The penalty is tiny. It's just under 33 cents times the number of months you were eligible but didn't sign up for a plan. So if you went a year without a plan, the penalty would be $3.93 a month. The government accrues the penalty until someone enrolls in a plan. Once they enroll, then the government assesses the penalty. Once they assess it, you pay it every month for the rest of your life. So, you know, sometimes I get calls from members and they say they'd like to sign up for a plan, and I'll say, well, how long have you gone without one? And, you know, I might get an answer like, well, it's been 5 years. So now the penalty is 60 months times 33 cents a month. So it can add up. But the penalty itself is a minor issue. The bigger issue is this, and I've had it happen twice with members who the doc and his wife sat right here in my office in the month of November. Now, these two couples, this happened a year apart, exactly November and February of each particular year. One of the docs didn't take any medications. The other took one generic. And they looked at the price of a Part D plan, which, you know, are not that expensive, but they looked at their Part D tax or surcharge because of their income from 2 years ago. And they said, holy smokes, I don't take anything, or I take this $2 a month medication. I don't want a Part D plan. Well, in February, a year apart, I got a call from each of their wives. Doc would like to sign up for a Part D plan. And I said, well, he sat here and told me he didn't want one. I know, but he's been diagnosed with cancer. At that point, I had to explain to the two wives, and it was a tough conversation, that they were outside of their initial enrollment period. They could not sign up for a plan now until the next fall during the Medicare annual election period. And even then, their plan wouldn't start until January 1st. So both families for 11 months had to pay for cancer medications out of pocket. That's not what you've worked your entire careers for and built up retirement funds to have it go down the drain because you didn't have a Part D plan. So it's devastating financially. So whether you take a lot or you take a little bit of medications, it's important to at least have a Part D plan in place. The way cancer is normally handled with Medicare, because I hear this all the time when I meet with people and we start talking about Part D, they say, well, you know, this Part D plan looks pretty reasonable. What's going to happen if I get cancer? The way things normally work with Medicare is if someone is taking a chemo medication that has to be infused in a hospital or a clinical setting, then that is normally covered under Part B of Medicare. But if they're taking one of the new oral medications, that would be covered under Part D. So I just, as an example, have shown you the cost of some of these cancer medications, some rheumatoid arthritis medications, and multiple sclerosis meds in terms of how much those things can cost, whether someone has Part D coverage or not. And it can be devastating having to pay that 11 months or 5 months or whatever. So that's the bigger issue beyond the penalty. So again, when you sign up for a Part D plan, whichever plan you go with, you're going to pay that insurance company. And again, that's out of your right pocket, if you will. But if your income filing joint back in 2018 was greater than 174,000, then the government, once they realize you have a Part D plan, is going to hit you with that tax or surcharge in addition to what you're paying the insurance company. So there are 30 standalone Part D drug plans sold in Michigan. Every one is different than the next, and that's why it can get very confusing. All 30 have their own drug formulary, their list of covered medications. Medicare in 2020 allows these Part D insurance companies, if the insurance company wants to pass on to us a $435 annual deductible that we would have to satisfy before we can access our copay amounts. Of the 30 plans in Michigan, I'd say probably 70% do pass the deductible on to us. Then there are a handful of plans that kind of split the difference with us. So what I mean by that is if someone's taking a tier 1 or 2 medication, then there may be a 0 deductible on those 2 tiers. If someone then starts taking tier 3 through 5 medications, then there could be the full $435 deductible, $290, $250. It just depends on the plan. On all these Part D plans, they have 3 pharmacy networks that you're going to want to pay attention to. There's a mail order network, a standard pharmacy network, and a preferred pharmacy network. If you can, you always want to deal with a preferred pharmacy network because your copays are always less money than if you were dealing with a standard pharmacy. Of course, the preferred pharmacy networks vary on all 30 plans. So there's a way on the plan that, you know, let's say you narrow your choices down to 3 different plans and you're trying to decide. On all of the plans' websites, they have a header called a pharmacy locator. It typically works like this. You would enter your home zip code. They'll ask how many miles from there do you want to search. You select that. Then you would mark the box for preferred pharmacy and hit search. So depending on how many miles you search from your zip code, it'll give you a listing of all the preferred pharmacies. And those are the ones you wanted to deal with because you'll save money. Now, one of the things that's strange as we become Medicare eligible and we have Part D drug coverage it seems like it should be reversed. But all of the drug discounts, the coupon programs, the drug manufacturers, nonprofit foundations, where they offer pharmaceutical assistant programs on expensive medications. Once you are covered by a Part D drug plan, none of those things can be used anymore. So the one thing that you can use on a Part D drug plan is you can use a pharmacy's drug discount instead of your Part D plan if the discount makes the price less than what you'd have to pay through your Part D plan. So I'll give you an example. My wife takes one of her medications is a tier 2 medication. On her plan, if I remember correctly, the tier 2 copay for a 30-day refill at a preferred pharmacy is $14. She uses CVS. CVS will sell her that medication for $8.62. So in that case, she a couple of years ago said to them, well, I'm not going to pay $14 for something you're going to sell to me for $8.62. So don't run that medication through my Part D plan. And they don't. So that's what that second bullet point is getting to. So if they're willing to sell you something lower than what you have to pay in your copay based on the tier that medication falls under, just don't run it through your Part D plan. All right, so the monthly premiums on these Part D plans sold in Michigan range from $13 a month all the way up to $105 a month. The average price is $33. Because of this disparity, before we meet with a member to actually review their situation and guide them and have them make their decision, we email to them prior to an appointment or a Zoom meeting in these times, prescription medication list. And we ask them to fill it out, give us a list of their medications, the dosage, and indicate how many times a day they take it. We also ask for their home zip code and the pharmacy they use. That comes back to us. We put their medications anonymously into a Medicare Part D plan finder, and then that helps identify which plans based on those particular medications might be a more natural fit for them for the current year. And then when we eventually meet with the member, instead of going through 30 different plans, we're able to talk to them about the top plans that would fit. At MDA, we don't handle all 30 plans. That would be an absolute nightmare. We handle about 9. So the choices are very broad and the range is good. The formularies list of covered medications is good. Again, a plan that someone may have in 2020 may not be the best plan for them in 2021. So again, we do the reviews in the fall for those plans too. This slide is the most confusing part of Medicare. Everyone who has a Part D drug plan will flow through some or all of this cost sharing structure on a calendar year basis. So again, using the example we started with, an individual starting their Medicare August 1st, 2020, they would begin this August 1st and it would reset come January 1st, 2021, they'd start over. So everyone starts at the bottom. And that is dependent on the plan that you've selected. So you may have a plan with a $435 deductible. You may have a plan with a 0 deductible. Whatever your responsibility is in that first stage, once you've satisfied it, Medicare will move you into the second stage, which is called the initial coverage stage. Now, on this illustration, Medicare they love to work off of national averages. But the point I want to convey is when you're in this stage, whatever tiers that your medications fall into based on the Part D plan that you have, and therefore whatever your copay amounts, dollar amounts are, those still come into play in this initial coverage stage. In this illustration, though, Medicare is saying that the participant will pay 25% for their copays, and their plan will pay 75% of the cost of the medication. That 25% copay amount, in my opinion, is high, because you may have copay dollar amounts on your plan that are a lot less than that in this stage. Once you hit $4,020 for the year, which is made up of what you paid out of pocket in the deductible stage, what you paid out of pocket for your copays in the initial coverage stage, and what your insurance plan paid in the initial coverage stage. Once all of that equals $4,020, then you get moved into what's called the donut hole. Now, most of us call it the donut hole. The Medicare program calls it the coverage gap, but it's better known as the donut hole. This donut hole has been closing over the last few years. 3 years ago, if you were on a name brand medication, you would have paid 48% out of pocket for your medication. And if you were on a generic, you would have paid 53%. So it's been closing over the last few years, but it's now reached the point where this is as tight as it's going to get. So if you get moved into the donut hole, now you're going to pay, your copay is a flat 25% of the price of that medication. If you come out of the donut hole before the year's up, then you'd go into the catastrophic coverage stage, and you'll pay 5% for the cost of the medication. Well, how do you get out of the donut hole? That number over on the right, Troop 6350, is what you'd have to hit to come out of the donut hole. And Troop stands for True Out-of-Pocket Costs. The 6350 is made up of your costs. What did you pay in the deductible stage? What did you pay in the initial coverage stage in copays? And what did you pay in copays in the donut hole? When those things equal 6350, then you get moved into the catastrophic coverage stage. This, how someone will flow through this 4-level chart, is totally dependent on the medications they take, how many they take, the cost of the medications, and so on. I have members that I deal with that never leave the deductible stage in the year. A lot of them never leave the initial coverage stage. I have some members that I deal with that hit that donut hole the 3rd week of January, and they enter the catastrophic coverage stage in February every year. So it's a very personal situation based on your medications. One of the things that you may have read, you may have seen it on TV, whatever, Medicare has kind of beat the drum, and I know they've released a lot of press releases to the media and so on saying the donut hole has closed in 2020. Well, I will tell you, kind of, sort of, not really. Because making a statement like that, to me, gives the impression that what a Medicare beneficiary is going to pay for their medications is going to remain consistent throughout the year. And the reason I say that is because of the way Medicare does their illustrations. So I'm going to go back for a minute. In their illustration, in this stage, they're saying you're going to pay 25% in your copays. And up here, they're saying you're going to pay 25%. So when Medicare looks at that, they say the donut hole's closed because the 25% is the same. And so there's no big change. Well, so I want to explain what the reality is. In July, Mary is in her initial coverage stage. That's where her copays still matter based on her plan. She fills 4 30-day prescriptions and pays her plan's copays for each tier 3 medication. And her copay on a tier 3 medication on her plan is $45 each for these 4 medications. So in July, in the initial coverage stage, Mary pays $180 in copays for those 4 medications. But in August, she has moved into the donut hole. She fills the same 30-day prescriptions, but now pays a flat $25% of the cost of those medications. Well, this is the cost of those 4 medications, and it comes to $3,805. Now she's got to pay 25% because she's in the donut hole. This is what she's going to pay for each med. In August, she's going to pay $951.25 in copays versus what she paid in July. So that donut hole has not gone away, despite what Medicare might say, because things change drastically in the donut hole still. Okay, at this point, let me get this off here. I think I had no questions. So do you have questions that I can answer? You can either go ahead and ask verbally or chat or through questions and answers.
Why do you think you have to, or Medicare?
I'm sorry, what was the mid part of the question? How do you, okay. So we have a question, how do you pick between supplements or Advantage? That is a great question. It's really dependent on the individual. A lot of our members either do travel a lot or like to travel a lot or hope to travel a lot in retirement. And, you know, a lot of you obviously are dentists, are doctors, and you understand the importance of provider flexibility. So a lot of folks in that category tend to lean on the side of Medicare Supplement because it's just a wide open national network of providers. Out of pocket risk tolerance is important, but everyone has different levels of risk tolerance. The amount of premium that you want to pay each month or are willing to pay comes into play. Over on the Medicare Advantage side, this wouldn't necessarily be true of our dentists, but you know, sometimes folks go with Medicare supplements, or excuse me, Medicare Advantage plans because they want the additional benefits that are built in, the basic dental, they may want vision, hearing, things like that, and you can't get those on a supplement. However, folks that go with supplements can still get a VSP vision plan, you know, separately. So it just really depends what someone's looking at. Some folks that are very, very, very healthy and maybe don't go to the doctor, you know, once in a while I hear from a member, well, I haven't been to the doctor in 5 years. Well, that person may feel more comfortable with a Medicare Advantage plan because they'll look at me and say, well, Rick, there's no way I'm going to hit that $5,000 out of pocket maximum because I don't go to the doctor. So they're willing at that point in their life to go with a lower monthly premium, and their risk tolerance for paying an out-of-pocket amount, they feel they're not going to hit it, so you know they don't care. The issue there is if they do run into health problems down the road, there is one company in the state of Michigan, and they're represented by a color. That's all I can say. They will never decline anyone who's applying for a Medicare supplement, like some of the insurance companies do. But they can certainly double the premium on someone applying for a Medicare supplement if that company doesn't like the individual's answers on the health questions. So there's just a wide variety of, you know, factors that come into play to help determine whether someone goes with a supplement or Medicare Advantage. If you are on no medications, do you still want to pick a G plan or not? So another good question. The G is a Medicare supplement plan. So that fills in the holes for Part A and B, those out-of-pocket risks. So it would be a D plan that you'd want to make a decision about. The drug plan. Now, again, none of us has a crystal ball. So if you don't sign up for a Part D plan, when you're in your initial enrollment period, you would not be able to sign up for one until the fall. And even then, it wouldn't take effect until January 1st. So depending on how you're situated financially, you know, if you're willing to run the risk of not having any type of prescription coverage God forbid, if you were diagnosed with some situation or condition where you had to take expensive medications, you would end up having to pay out of pocket for those until you got around to January 1st again.
Right.
But that's, you know, that's everyone's individual call to do that.
Your wife is a dentist and you can just be on her plan through the MDA. You have to take Medicare.
I'm sorry? Was that a question?
No, I typed a question.
Oh, okay, let me look.
You have on the speaker.
Okay, can you switch from a supplement to an advantage plan and back from year to year during the annual election period? If the situation changes, would you suggest there was a benefit? The answer from a technical standpoint is every fall between October 15th and December 7th, yes, you could switch back and forth if you wanted. You could go from a supplement to a Medicare Advantage plan. There aren't any health questions on a Medicare Advantage application. So you would be accepted by that insurance company. Your rate would simply be based on the county you live in, and the plan would take effect, January 1st. However, if you're going the opposite direction and you have a Medicare Advantage plan, and in the fall you want to complete an application for a Medicare supplement plan, you're going to answer 3 pages of health questions on the Medicare supplement application. Again, a carrier can decline you, or they could double your rate. That would be the worst case scenario, but that particular company that could double your rate, they would still grant you the policy. There is, in those situations, say switching a Medicare supplement or moving from a Medicare Advantage to a supplement plan, there is what I call a walk back period, where I can walk you back from the cliff, if you will. So the way it works with this company that won't decline you is they'll look at the applicant's answers to the questions. Their underwriting department will. They'll get in touch with me and they'll say, all right, we are going to extend this premium to Dr. Mary. You have 10 days to get back with your client and find out if they still want to move forward with this change. So at that point, then I get in touch with Dr. Mary and say, I need to know whether you want to do this or stay put. So just because someone fills out an application, they're not getting locked into some unknown rate because they don't even know what the rate's going to be when they're switching. So there is a point where they can make a logical decision and either say, yeah, this is worth it, I want to switch, or no, I'm going to stay put. Okay. This is a great question. I'm currently receiving SSA disability benefits. When do I have to sign up for Medicare, or will I automatically be signed up by SSA? I will be 63 next month. So what should have happened, and hopefully it did happen, is when you were granted the Social Security Disability Award, they should have signed you up for Medicare Part A, the hospital coverage. Then when someone is on Social Security disability for 24 months, in the 25th month, they are then eligible to be enrolled in Part B. At that point, the experience that I've had with some clients is I would take, if it were me, I would take it upon myself to actively enroll in Part B and not leave it up to the government or Social Security to do that, because I've seen too many people fall through the cracks who did not get signed up for Part B. Now, there's another catch to all of this, which, boy, I sure don't agree with, but I don't run an insurance corporation either. What happens when someone is under age 65 and they're on Medicare because of disability, the insurance companies take the standard rate for a Medicare supplement plan and they pretty much triple or quadruple the premium. So let me give you an example. Let's say for a plan G for a 65-year-old female, the plan G runs $120 a month. But for someone under age 65, they're going to charge like $489 a month for that plan. So they really sock it to the folks that are under age 65 and are on Medicare because of disability. So in those cases, and I get about 5 of those a year that I deal with, we normally would have an individual under age 65 on Medicare enroll in a Medicare Advantage plan, because that premium is simply based on the county that you live in. And then as you approach age 65, if you want to be covered by a Medicare supplement plan, you have now entered, even though you've been on Medicare, you have now entered your initial enrollment period that you get as you're aging into Medicare at 65. You'll be guaranteed issue on a Medicare supplement, and they will charge you the standard rate. Now, here's one other point to that. If someone is already covered by a Medicare supplement because that's what they wanted, and they're paying $400 and some a month, but now they're aging into Medicare at 65, we have them fill out a new application when they're in their initial enrollment period. We have them fill it out as if they were aging into Medicare, which they are. And at that point, they are granted the standard rate, which would be, $100 and some. So there's a rate reduction in those cases. So it can get tricky, but the Medicare supplement plans are so expensive for someone under age 65. Let's see. Any other questions? So again, for those of you, that might be turning 65 in the coming months or whatever, 90 days in advance of the first day of your birthday month, you're going to want to apply online. Hopefully you'll get through those security questions. They're not easy, because a lot of us don't even remember what we had for lunch yesterday, rather than who did I have a loan with in 1988 or whatever. I'm not doing any personal meetings right now, obviously, because of COVID-19, but I'm certainly doing phone meetings. I'm doing a lot of individual Zoom meetings where we get into, plan choices and people's situations, things like that. Now, the other thing that occurs is when one member of the couple is aging into Medicare, let's say they're on a group plan, they may be at that point displacing their spouse from the current coverage. And it's kind of like putting a jigsaw puzzle together when that happens. We have to kind of review how many folks are on the current group plan, whether that group plan still comes into play, whether the displaced spouse can go on COBRA, whether their only option is to go on an individual health plan. So we put all those pieces together. We also help with the paperwork to terminate your current coverage, so you're not going to continue to get billed for it. So there's a lot of pieces that get put together when we have the personal meetings, the Zoom or the phone meeting. So let me give you my email address and also my cell phone number. The phone number at the office right now is being forwarded to my cell phone because I'm working at home. I'm in the office today, but my email address is rseely@mdaifg.com. So it's rseely@mdaifg.com. My cell phone number is 517-896-3510. When I'm in these individual meetings, these things, you've by attending the seminar today, the webinar, you've knocked a lot of the meeting time out already because you have all this background. But when I'm in a meeting with someone who's starting from scratch, those meetings can go 2 to 2.5 hours sometimes. So if you call or email me and I don't get back to you right away, it's probably because I have a series of meetings that I'm tied up in. So rest assured, I will get back with you. It may not be that same day in some cases, depending on what I have on the calendar, but I will get back with you. Some of you may want to talk before you apply for Medicare. Some of you may feel comfortable enough to go in and start that process and then have a meeting after you get your card or before you receive your card. It just depends, whatever's most convenient for you. But we're definitely here to help. We have a lot of members that are aging into Medicare. So we'll do everything we can to help you and make it a smooth transition. So I want to thank you for your attention and your time, and hopefully I was able to pass on some information to you today that will be helpful. So thank you very much and stay safe. Bye-bye.
Good job, Rick.
Thank you. Appreciate it. Talk to you soon.
Later.